Welcome to Fluid and Electrolyte Disorders. This is a review of fluid and electrolyte disorders. Another video is available for the basics of fluid and electrolytes. Please note our standard disclaimer in the small print to the left. It basically states that we do everything we can to provide accurate and up-to-date information. However, this video is not designed to replace your professor's information, but instead to supplement it. So fluid and electrolyte imbalances can occur even in healthy people, but it's usually mild and self-corrected. However, fluid and electrolyte imbalances can be life-threatening, especially for patients at risk, including the elderly, those with chronic renal and endocrine disorders, and those patients that take medicines that affect fluid and electrolyte balance. So we're going to start with fluid volume deficit and fluid volume excess. And so the most confusing thing about fluid volume deficit is it primarily means dehydration, but as you'll see, there is one type that actually is too much water. So no water, no salt, or both. That's what makes fluid volume deficit confusing sometimes, because our symptoms can vary based on the cause of fluid volume deficit. It's not just water loss that exceeds water intake, although that is the most common. So certainly that's what you should learn. Just don't put in your mind that it is absolutely always this, because if you're being tested specifically on fluid and electrolyte disorders, there is certainly a chance that you could be tested to see that you understand that lack of salt, too much water, can also fall under fluid volume deficit. Now in a broad test like NCLEX, something like that, that will not be the case. So moving forward, fluid volume imbalances are typically accompanied by electrolyte imbalances. Infants, clients with neurologic or psychologic problems, and older adults who maybe are unable to perceive or respond to thirst mechanism are at risk for dehydration. So the types of fluid volume deficit. No water would be hypertonic fluid volume deficit. And this is caused by profuse sweating, hyperventilation, DKA, fevers, diarrhea, renal failure, and diabetes insipidus. This is primarily losing water. No salt would be considered hypotonic, and they're primarily losing electrolytes. This is the least common cause of fluid volume deficit, and the problems occur because they are hyponatremic because of dilution. So look at the causes: water intoxication, drinking too much water. We usually see that either with marathon runners or long distance exercisers that haven't controlled their fluid intake, or maybe bodybuilders getting ready for a competition and so they drink a gallon of water in an hour, or in those contests where they're seeing, radio station is seeing how much water somebody can drink. That's typically what it is. The other time you might see water intoxication is when somebody has a psychological problem like an OCD where they're constantly drinking water. Sometimes this no salt can occur with chronic illness or renal failure or malnutrition, but again, water intoxication is the most common one we see. So what happens here is the cells begin to swell, and then it causes very bad neuro problems. And then both no water and no salt is isotonic fluid volume deficit, and this happens because they're losing both water and electrolytes. This is our typical dehydration that we think about. They've been in PO, or they're having very poor intake, or it could be even from a hemorrhage. So without any loss of water, then it's called relative dehydration. We truly have what's called just a fluid shift. So fluid volume deficit symptoms, primarily we're going to talk about what happens with the common ones, not with the hypotonic. I just want you to remember there is that potential to have a deficit with that. So our typical fluid volume deficit symptoms: low blood pressure, high heart rate, dry mouth and thirst, rapid weight loss, low urine output because they don't have anything coming in, confusion, lethargy from those changes in the brain cells from sodium. And then typically they have a high specific gravity, a high hematocrit, a high BUN, and then a low sodium. and a high osmo. So the high hematocrit, high BUN happens because of the dehydration, and so it's kind of a falsely elevated hematocrit from that concentration of the fluids. Now the low-grade fever, they can sometimes have a low-grade fever, and that's because they sometimes will have blood vessel constriction due to the hypovolemia, and so they can get a little bit of a low-grade fever. Now, we wouldn't see that increased hematocrit if it was a hemorrhage, but really everything else we would. Treatment. Fluids. Of course, that's what they need is fluids. If they're alert, oral fluids are best. If they're not alert, or if we can't get enough through oral fluids, then typically we give isotonic fluids. So normal saline or lactated ringers. You should not add any potassium until their urine output is increased. Remember, potassium is excreted through the kidneys. So if we don't have good urine output, and that's considered a minimum of 600 mils in a day, then we should give no potassium supplements at all. Certainly monitor daily weights, strict I's and O's. And then based on the cause of their fluid volume deficit, they may need other medications like antibiotics or antidiarrheals or antiemetics, antipyretics, just to stop the symptoms that were leading to the fluid volume deficit. So how do we know our treatment's working? We see a change in all those symptoms. Particularly, we see good urine output or increased urine output, and we see that heart rate drop. Fluid volume excess. This happens when there's increased sodium and water. So typically we think of it as overhydration or hypervolemia. Again, we have isotonic, hypotonic, and hypertonic. So hypervolemia, too much fluid in the extracellular fluid causing circulatory overload. This is typically isotonic. So it can happen just from too much IV fluid, where they were running at a rate higher than maintenance, or the pump fails and overloads them. Also, it can happen with kidney failure or even use of corticosteroids. Hypotonic is water intoxication, the same thing we talked about with fluid volume deficit. So psych problems are on there, and those would again be where they're compelled to drink water. They can't control themselves. But some other things that can cause it are the wrong type of IV fluids, congestive heart failure, SIADH, syndrome of inappropriate antidiuretic hormone, or even wound irrigation. Sometimes the fluids we use for wound irrigation mess up the sodium balance because it causes exchange of fluids. And then hypertonic is too much sodium intake. This is pretty rare that they have eaten too much salt or taken too much salt in, but sometimes if we have to give 3% saline IV for to try to cause a fluid exchange, maybe they've got a neurologic problem and we have to give 3% saline, we could lead to this problem of fluid volume excess, or if we give too much sodium bicarb. Symptoms with fluid volume excess are exactly as you would think: rapid weight gain, edema, not always pitting though, and that can sometimes tell us what the problem is if we don't have pitting edema, high blood pressure, abounding pulses. Sometimes they'll have increased urine output if the kidneys are actually working normally. JVD, crackles, dyspnea, we know that's a sign that there's fluid in the lungs usually. Decreased level of consciousness sometimes, and then a low hematocrit, low BUN, low osmo, high sodium. So the low hematocrit, low BUN is from hemodilution. So it's a not necessarily correct value. It's because the ECF is too diluted. Let's see, neck vein distension is another one we might see. The treatment, diuretics. Usually they'll try to go for osmotic diuretics like mannitol because those prevent severe fluid electrolyte changes. Fluid restriction, particularly no IV fluids. A common test question that I see out there is something about all the symptoms of fluid volume excess and then something about giving IV fluids. We would want to stop all the IV fluids usually, unless we're going to try to exchange fluids. Typically a sodium restriction too, and then daily weights and strict ISO so we can monitor their balance. Now, before we get into each of the different specific electrolyte imbalances, just a reminder of some lab normals. I had this on the fluid and electrolyte basics video, but this is just a quick way to try to learn some of these normal ranges. I never suggest people learn ranges because then you have to memorize two numbers, but this is a nice fast way to look at just the middle number and looking at it by fours. So, I always suggest you learn just the middle number anyway, but this certainly shows how easy it is to do that. So remember too, as we start to talk about these disorders, know that all the symptoms that we'll talk about will worsen when the electrolyte values change rapidly. If it's a chronic, slow change, the body often tends to adapt and the symptoms aren't near as severe. So sodium, back to lab values. I know that you see different lab values in different books. These are kind of the accepted norms, except maybe potassium. It typically is 3.5 to 5.0. So sodium, 135 to 145. We know that's the major cation of the extracellular fluid. It regulates body fluids. It determines whether water is retained, excreted, or moved from one space to the other, and it's the primary cause of osmolality. Change in sodium affects plasma volume. It'll affect blood pressure. It affects the ICF and the ECF, the intracellular fluid and the extracellular fluid. We also see sodium combining with chloride or bicarb to promote acid-base balance. Sodium is stored in the kidneys. It's regulated by ADH through dilution or concentration. It's also regulated by aldosterone, which conserves sodium, and then the natriuretic peptides are stimulated when sodium is high. We mostly get sodium from our food, and most of our output is through the urine and the sweat. Also remember, sodium has an inverse relationship with potassium. If one is high, then typically the other one is low. When you think of sodium problems, think of brain. So hypernatremia or high sodium. Pathophysiology-wise, excitable tissues lead to irritability and enhanced response to stimuli. So as the sodium level gets higher, there will be less response to stimuli. So this causes hyperosmolality, which causes a shift of water out of the cells so the cells become dehydrated. The causes can be a relative increase because you have increased water loss, so it makes you have ultimately more sodium, or actual where you truly have more sodium gain. So too little sodium excretion or too much sodium intake. And I have some of the causes there. Increased sodium excretion or less sodium excretion is renal failure or corticosteroids. Increased sodium intake, eating too much salt or too much sodium in the IV fluids. And then the water loss side is fever, infection, hyperventilation, sweating, diarrhea, and dehydration. Signs and symptoms. There's a great little book by Mosby's. It's a memory notebook of fluid electrolyte imbalances. That's where these nice little mnemonics come from. But you are fried. So fever, restless or irritable, increased fluid retention, edema, and decreased urine output, dry mouth, and the egg there to remember that goes with it. So again, think brain. Their mental status is altered. They can even get seizures from this, and unless they're hypervolemic, too much water, which is rarely the case, then you would see that blood pressure to be increased. So what do you do about hypernatremia? Treat the underlying cause. So if they don't have enough water, fluid replacement. If they have too much sodium, don't put salt in the IV fluids. Give diuretics. Put them on a sodium restriction. Avoid high sodium foods, so particularly canned foods, lunch meat, Chinese food, sodas, dairy is high in sodium. Those are the kinds of questions that are asked on exams. They know you know bacon and lunch meat. They want to see if you know the other stuff. Seizure precautions, because that's always a risk. And then if it's severe, they can actually do dialysis. Really, really important. Reduce sodium slowly. If we try to drop it fast, then we can cause swelling in the brain from those fluid shifts. Hyponatremia, or low sodium. So this either pathophysiology wise, the cells swell and we have decreased membrane depolarization. So as the sodium drops lower, the cells becomes excitable. When there is too little sodium in the tissue fluids, then water moves into the cells. Usually this isn't a problem because the tissues will expand, but in the brain, there is no room for expansions. So most symptoms of hyponatremia are related to the brain's inability to expand in the cranium. So this is low sodium occurs from water excess, too much water, or loss of sodium. It's the most common electrolyte disorder in the U.S. and occurs frequently in the seriously ill. So if we have too much water, that could be from drinking too much, polydipsia, like we see with diabetes. Freshwater drowning can make that happen, and SIADH, syndrome of inappropriate antidiuretic hormone, and congestive heart failure. Increased excretion of sodium, so we're losing too much sodium, happens with sweating, diuretics, GI wound drainage, particularly in renal disease, or decreased intake of sodium. Typically not a problem. We usually get too much sodium in our diets, but if you were NPO for an extended period, you were on a very low sodium diet, or you had severe vomiting and diarrhea, that could cause it. Symptoms that we see, most symptoms again are related to the brain's inability to expand. So we'll see CNS neuro symptoms, confusion, headaches. It can progress to seizures and coma. Sometimes they'll have abdominal cramps, nausea, vomiting. They could have signs of hypovolemia or hyper, either one, depending on what's going on. So what can we do about this? Usually we can't fix this by adding sodium to the diet. So we usually have to give the 3% saline. But when we give 3% saline, we have a big risk for fluid overload. So you want to watch for crackles, edema, bounding pulses. That's oftentimes a test question. What do we watch for when we give 3% saline? It shouldn't say normal saline, it should say saline. If the hyponatremia was caused by fluid excess, then we'll actually need a fluid restriction. And they might need osmotic diuretics like mannitol because it will cause excretion of water but not sodium. If it was caused by something like SIADH, then we have specific treatments for that, lithium, declamycin. Potassium. 3.5 to 5 is the normal. Notice that's a very small number because it's the primary ion of the intracellular fluid, and that's not what we measure with blood draws. Sodium potassium pump moves the potassium into the cell, pumps the sodium out. We really have no hormonal controls for potassium. The primary source of reabsorbing potassium is the kidneys. Now, aldosterone does increase sodium, and it will decrease potassium by having the kidneys excrete it. So it's kind of a hormonal control. The primary reason potassium levels are high, the most common, is that kidney function is impaired. The kidneys are not working right. So our normal source of potassium is the diet. It's poorly stored in the diet, so you actually have to have it every day. And our primary route of loss is the kidneys. And then I listed some of the common foods. Some of them you think of, OJ and bananas, but some of the others you might not have thought of. Another thing to think about with potassium is it increases when the pH is low. So if the body is in acidosis, hydrogen ions will shift in and out of the cells, and potassium will shift in the opposite direction. So it will cause it to increase. When you think of symptoms associated with cardiac problems, think heart. It disrupts electrical conduction, whether it's high or whether it's low. Hyperkalemia, increased potassium. Patho here is increased cell excitability. It takes less stimuli to excite, so it may cause spontaneous discharge of the cells. So the body is more sensitive to small changes in potassium levels than any other serum electrolyte because it's very important for cardiac function. We can get false high results if our lab specimen isn't drawn correctly. If you shake the tubing, the red top tube after you draw potassium, it can break the cells up and cause it to be higher than it really is. So if we have a high potassium that's unexpected and they've got normal kidney function, we need to rethink how we drew it. So the cause, kidney failure is the most common. Some other things that might cause it is use of salt or potassium supplements. Salt supplements have potassium in it and people don't realize that. So they're on a low salt diet. They start using those salt substitutes all the time, their potassium goes up. Getting old blood could cause that because the cells have been destroyed and they release potassium. So anything that causes cell destruction, like crushing injuries, acidosis, as we mentioned, hypoxia, exercise sometimes if the body's just in a catabolic state, and then people that use potassium-sparing diuretics. The primary one we think of is spironolactone. That's always asked on tests. All right, signs and symptoms. Here's another mnemonic for you. Murder, muscle weakness, urine. It may be oliguria, decreased urine output, or anuria, no urine output. Because remember, the kidneys are what get rid of potassium. Respiratory distress, that's really because of the muscle weakness. So respiratory muscles are weak. Decreased cardiac contractility, EKG changes, and then reflexes. They could be hyperreflexic or they can be areflexic. So oftentimes they might have muscle weakness, cramping pain, and then it progresses to no reflexes. What can you do for high potassium? Well, you've got to put them on a cardiac monitor. Anything for potassium on a cardiac monitor. And then you've got to get rid of that potassium. So K-exolate is a great drug that binds with potassium, pulls it out of the body. We can give that orally or we can give it as an enema. Calcium gluconate or glucose and insulin IV. Those combinations also help move potassium into the cells. It exchanges sodium ions for potassium ions. And that's the glucose and insulin. So if we give the insulin, we got to give glucose so that we don't drop their glucose levels. So you give calcium gluconate or glucose and insulin. If their kidneys are functioning, you can give them Lasix to try to get some of that out. We want to stop potassium in the IV fluids. Again, seems like an obvious thing, but one that gets missed on tests a lot. Have them avoid foods high in potassium. Again, something you miss on tests a lot. And it's because you see potassium and you immediately jump to bananas and OJ and you forget to read carefully and see, is it a high potassium and I need to restrict it, or is it a low potassium and I need to give it? So read carefully when you're looking at endocrine and electrolyte questions. If it's severe, then they may need dialysis. Otherwise, we can cause severe cardiac problems. Hypokalemia or low potassium. Patho of this, decreased excitability of the cells, especially in the nerves and the muscles, so they are less responsive to stimuli. Again, this is very important for cardiac function, so low is as bad as high. Causes: vomiting, NG suction, diarrhea. Diuretics, we know that diuretics make you pee more, so you are getting rid of more potassium unless you're using potassium sparing, spironolactone, but usually they're not. Laxatives will also lower the potassium, and so will insulin. Notice we said that's a treatment, so obviously it lowers it. Alkalosis, the opposite for high potassium. Alkalosis lowers potassium. And then rapid cell building, that's a pretty esoteric one I wouldn't necessarily memorize. Aldosterone too will lower it because remember it causes it to be decreased in the urine. Signs and symptoms, dysrhythmias, weakness. So think of everything as slowing. Their muscles are weak and slow. They might get a paralytic illness or have ileus or have constipation, slow the gut down, low blood pressure, weak pulse. As you learned a long time ago, it will increase the risk of digoxin toxicity. Again, please read those questions carefully. You make so many silly mistakes on these because you just don't read carefully. So what do you do for hypokalemia? Watch for dig toxicity because we know that's a risk. Of course, cardiac monitor. And we want to give them the foods high in potassium. Potassium IV. I'm going to give you the rules for that because that's always asked, really important. If they need diuretics, give them spironolactone, the potassium sparing. You can see how this gets confusing in test questions. Okay, so look at the red box to the left, the potassium administration. Here are the rules for that. You must have urine output, and you must have at least 600 mils a day before you can give any potassium supplements because we have to be sure that the body can expel that potassium once we give it. Otherwise, we're going to send them completely to the opposite side with hyperkalemia. You never give it IV push. We don't say that about very many things, but you never do. Now that does not mean you don't give it by bolus. You do give it by bolus, but that's in an IV piggyback, not IV push. When you're giving potassium, you must be on a cardiac monitor. You want to assess that IV site often because it's very irritating to the vein. We prefer to give it by a central venous catheter, but that doesn't mean we have to. That's often missed on test questions. So just because we prefer it doesn't mean that we have to do it that way. You do always dilute potassium. We'd never give it straight. Even in a piggyback, it's always diluted. Never more than 20 milliequivalents in a bolus IV piggyback, and never faster than over an hour. Sometimes 2 hours. Always on that cardiac monitor. Now the last thing again is confusing because above I say 20 milliequivalents in a bolus, and then I say the max concentration of IV fluids is 40 milliequivalents. Look at the thing, 40 milliequivalents per liter. So your IV bag that's hanging there, your liter bag, could have up to 40 milliequivalents in it, not in a bolus. 20 milliequivalents for bolus, 40 milliequivalents in a liter of IV fluids. Calcium, 9.0 to 10.5. As we know, primary source is the bones. We have free or ionized calcium versus bound calcium that's attached to proteins. What we usually measure is free or ionized calcium. The other thing about calcium is it affects transmission of nerve impulses and it affects the heart and muscles, but it also affects blood clotting. We store calcium in our bones, but remember to absorb it, we must have vitamin D. Primarily, we get calcium from dietary intake and absorption through the intestines. Parathyroid hormone causes calcium to increase because it tells the body to release it from the bones and then increases vitamin D activation and decreases the kidneys from excreting calcium. Calcitonin is secreted by the thyroid and it decreases calcium levels by inhibiting bone resorptions. So it works just exactly opposite of parathyroid hormone. Also, calcium phosphorus have an inverse relationship. If one is high, the other will be low. If one drops, the other will go up. Symptoms-wise, if it's low, they'll get excitability and tetany of the muscles. If it's high, that can cause heart arrhythmias and interrupts the muscle cells. So hypercalcemia. I don't have a lot of information on this because we don't see this as much. There's some very specific causes. Hyperparathyroidism or hyperthyroidism, that should be easy. They're both high. Malignancies, particularly breast cancer or lung cancer or multiple myeloma. Vitamin D or calcium overdose, that should be a given. Prolonged immobilization, not moving around, not having any weight-bearing activity, and then renal failure or use of glucocorticoids. Signs and symptoms: lethargy, confusion, depressed reflexes, severe muscle weakness. They can get fractures, kidney stones. And another thing is faster clotting times. And that's important because that puts them at risk for a DVT. So try to put that all together. Immobilization, is risk for DVT, so maybe you can put that together to remember this. Treatment. We want to try to get rid of calcium through the urine with a diuretic like Lasix. Also, hydration. We hydrate with just normal saline. That promotes excretion of calcium. Drinking a lot. 3,000 to 4,000 liters a day, lots and lots of fluid intake. We can give synthetic calcitonin. If they can do weight-bearing activity, that helps. And then there's another thing we can give called mithrasin. This is a calcium chelator, so it inhibits bone resorption. Another thing is no antacids. What does Tums have in it? Calcium. So a lot of the antacids have calcium, so we typically don't give any. If this were severe, they might need dialysis and cardiac monitoring. Now, hypocalcemia or low calcium is the one we talk about the most. So causes for this: removal of the parathyroid. Multiple blood transfusions can cause this. Immobility can cause this too. Malabsorption syndromes, decreased vitamin D intake, renal failure. These are the typical things that we think of. Some drugs can cause it, and then postmenopausal women are at higher risk for this, and we know that. That's not something we need to memorize. The signs and symptoms are what you want to know here. So another mnemonic: CATS, convulsions, arrhythmias, tetany, spasms, and stridor. Not good things. Now, what are the pictures that we see there to the left? We see on the top Trousseau's signs. So this is carpal pedal spasms when you inflate a blood pressure cuff. So how we often see it is we put the blood pressure cuff on to do a blood pressure, and all of a sudden their hand twists down like you see in this picture. That especially if they've had thyroid surgery, you should think about hypocalcemia. Another thing we see is Chvostek's sign. That's the picture on the bottom where you tap the facial muscle, you tap over the facial nerve, and it causes their face to twitch up like that. Now, typically they'll describe these signs and want to see if you know which one is which. So don't just memorize Chvostek's and Trousseau's. Make sure you know which of those is which is why I put those pictures up there for you. Stridor, spasms in the tingling around the mouth and the throat certainly are bad signs that we should worry about. Treatment: calcium supplements, obviously. They're oral or IV. We never give them IM. Give them a diet high in calcium with vitamin D supplements because they've got to be able to absorb it. And then particularly people who have had a thyroid or a neck surgery, we've got to watch for this. This is the biggest risk. You're going to talk about it again in endocrine, and when you talk about thyroid and neck surgeries, you have to be watching for this and be prepared. Phosphate imbalances, and then we'll quickly do magnesium imbalances. We won't talk about these as much, so just cover them quickly. Normal phosphate is 3.0 to 4.5. Most phosphorus is in the bones and the ICF, the intracellular fluid. It helps us with nutrient metabolism, acid-base buffering, and just balancing calcium. Again, If calcium is low, phosphorus will be high. Phosphorus is high, calcium will be low. It's an inverse or reciprocal relationship. Kidneys, the major route of excretion. We find most phosphate in fish or dairy, cheese, milk, yogurt, and then meats. And it's primarily regulated by the parathyroid hormone. So hyperphosphatemia, the cause, typically renal failure or tumor lysis syndrome. So you'll talk about it again when you talk about cancer complications. Signs and symptoms. Most of these signs and symptoms are usually due to the low calcium, not really to the phosphorus. So we see calcium deposits in the joints, sometimes the skin, kidneys, or eyes. Low calcium, and then the symptoms of low calcium, tetany, neuromuscular irritability. Treatment, fix the hypocalcemia. That will automatically fix the high phosphatemia. Hypophosphatemia is usually more problematic, especially if it's chronic. So typical causes malnutrition or malabsorption, alcohol abuse, or taking too many antacids. Signs and symptoms, CNS depression, confusion, muscle weakness, sometimes fractures. And the treatments, if it's chronic, Nutriphos, the oral supplements, decreasing their calcium intake, and then sometimes they can do IV phosphate, but this can be risky because you can cause a rapid, severe low calcium. And if they're low phosphate, hypophosphatemia, then we want to stop antacids and calcium supplements. Magnesium, normal 1.3 to 2.1. I wouldn't memorize that one either. Most magnesium is stored in the bone, found in the intracellular fluid, and it affects blood coagulation and skeletal muscle contraction. Typically, we get it from food, avocados, spinach, meats, dairy, and veggies. It's regulated by GI absorption and renal excretion, although we don't really know how that works or why that works, but that's how it's regulated. These imbalances, again, look very similar to calcium imbalances, and oftentimes they can have potassium imbalances too. And magnesium can affect the heart too, and the muscular function. So hypermagnesemia causes increased intake from things like milk of magnesia, Maalox. We need to be really careful if they have chronic kidney disease that we don't give them milk of magnesia or Maalox. Signs and symptoms, lethargy, nausea, vomiting, loss of their deep tendon reflexes. They can even have respiratory and cardiac arrest with magnesium imbalance. High magnesium, you will talk about this when you do cardiac dysrhythmias. Treatment, avoid those milk of mag, Maalox, increase fluid intake, and they may need dialysis if it's severe. Hypomagnesemia causes prolonged fasting or starvation, chronic alcoholism, or diuretic use. Signs and symptoms, hyperactive deep tendon reflexes, but confusion, tremors, seizures, also cardiac problems. There are oral supplements, of course, we could give for magnesium, but we can just increase their oral intake too. How nice, peanut butter, chocolate. I could do that. If I had low magnesium, I'm sure I could make that happen. We can give IV or IM magnesium, but if you give it too fast, it can cause cardiac or respiratory arrest. Not so good. Last thing we'll cover is just a review of medications. Real quick review. So the loop diuretics, like Lasix, cause a big loss of potassium. Thiazide diuretics, like HCTZ, hydrochlorothiazide, they potentiate digoxin and cause a loss of potassium. Potassium-sparing diuretics, you have to know this. Spironolactone is always the one, but there's also triamterene. These potentiate digoxin and lithium. And remember that too much potassium can be harmful too. Electrolytes. Potassium's the most common one that we give. So remember all the safety, all those rules we talked about for giving potassium. Guaranteed those questions will be asked on a test. Guaranteed. And then K-oxalate. Remember, this is the drug that binds with potassium to remove it from the body. Comes in a liquid. It looks like molasses almost, or powder, or in an enema. If they're taking antacids, that will make this medicine not work very well. So we don't want them to take antacids with it. General rules for giving diuretics. Don't give them at night. Why? They're going to be up all night peeing, and then they get no sleep, and that causes chronic problems. So you got to give them during the day. They're commonly given with antihypertensive, so most people on an antihypertensive are taking some sort of diuretic, and all but the potassium sparing will decrease potassium levels, and so they need to be eating more potassium or taking supplements. Watch for more videos coming soon. Look at our website for additional information. And we thank you for watching. We welcome your feedback. So make comments, make suggestions, ask us questions, like or dislike the videos, share the videos, and please subscribe to our channel so you'll see our new videos as soon as they come out. Again, thanks for watching.